Hello everyone, I'm Ranjan Dahal, Cardiology Fellow at Texas Tech University Health Science Center, El Paso, Texas. Today, I'm presenting an interesting case of acute limb ischemia presented as hip weakness, numbness, lower extremity cramps, ultimately explained by ipsilateral ostial common iliac artery occlusion. We do not have any disclosures. Clinical history: 71 years old female, initially presented with acute onset right lower extremity pain for preceding 12 hours. Her symptoms started as cramps in the right foot, which gradually ascended to right hip, followed by weakness and numbness in right posterior thigh and gluteal region. She also reported non-lifestyle limiting intermittent claudication of right leg for preceding 2 years without any specific evaluation. Past medical history included COPD with multiple exacerbations, breast cancer, former smoker, and remote methamphetamine use. Initial findings were significant for tenderness in right inguinal region. Right common femoral and right popliteal artery were 1+ compared to 2+ in the left side. Right dorsalis pedis was palpable 1+ with intact capillary fill. Motor and sensory examinations were intact in the right foot. However, right hip muscles were considerably weaker, 2 out of 5, associated with hyperalgesia of right hip and right thigh regions. Right hip fracture was ruled out with hip radiograms. Right lower extremity arterial Doppler revealed markedly reduced flow velocities from right external iliac artery to the distal branches of right tibioperoneal trunk. The initial clinical evaluation did not find any evidence of acute limb ischemia as per 2016 ACC/AHA lower extremity PAD guidelines. However, considering ALI as one of the differentials, she was started on aspirin, clopidogrel, and anticoagulation with heparin infusion. However, few hours later, right lower extremity weakness worsened and foot was cold to touch, along with loss of right dorsalis pedis pulse even on bedside Doppler evaluation. With the diagnosis of acute limb ischemia class 2B, she was emergently taken to catheterization lab. The peripheral angiogram showed occlusion of ostial right common iliac artery with collateral flow from left to right. The next image shows widely patent right common femoral and its distal branches after occluded right iliac arteries were crushed. The first image shows widely patent right popliteal artery and its distal branches. However, the next image shows poor flow to the distal right leg and almost no flow to the right foot. The first image is after first pass of mechanical thrombectomy catheter, and the next one is after second pass of the catheter. The first image is after balloon angioplasty, and the next image shows thrombus formation while balloon expandable stent was being deployed. The next image shows distal embolization after stent deployment in right common iliac and external iliac artery. However, after repeat passes of thrombectomy catheter did not lead to brisk anterograde flow, so decision was made to start intraarterial alteplase infusion using unifuse catheter. Peripheral angiogram done next day showed widely patent, well-opposed stents in right common iliac artery and external iliac artery with no left to right residual collaterals. The other image shows widely patent right common femoral artery and its distal branches. Here we can see widely patent right popliteal artery and its distal branches. and brisk three vessel flow to the foot as well. The patient manifested complete recovery of all the neurovascular deficit. Her right foot was warm and well perfused. Right hip strength improved back to normal, including her sensation too. She was able to ambulate without assistance on discharge and was discharged on aspirin and clopidogrel. Acute limb ischemia affects around 15 and 26 persons per 100,000 each year in the United States and carries a very high morbidity and mortality if not recognized and addressed promptly. The classic 6Ps may not be present, especially if there are collateral blood supply, like in our case. In addition, the presence of another potential differential diagnosis can add to the diagnostic dilemma and further delay the required emergent care. On initial evaluation, our patient did not meet the criteria. However, her clinical presentation quickly evolved into ALI class 2B. This case demonstrates the perplexities in making diagnosis with such atypical presentation of acute limb ischemia. Ostial occlusion of common iliac artery is a rare phenomenon, and acute limb ischemia with hip weakness secondary to iliac artery disease has not been described. Mechanical thrombectomy led to brisk anterograde flow, but distal embolization during stenting of common iliac artery necessitated alteplase infusion. Initial alteplase infusion followed by staged primary angioplasty and stenting of common iliac artery might have prevented the distal embolization. The clinical outcome of endovascular therapy was phenomenal with complete resolution of her symptoms and signs. This case highlights the presentation of acute limb ischemia, which might not follow the stages of ALI classification of 2016 ACC/AHA PAD guidelines. This concludes my presentation. Thank you.